I will give you a brief presentation of the present status and our present activities and the future outlook. First of all, I should say that I'm not here by myself. I'm here by behalf of the Azure Technical Committee, and here you can see the members of the committee. As you can see, we are a bunch of physicists across the Europe and United States, and for the guidelines, for the particular guidelines, we always invite experts on the particular field or specific clinical applications, and typically these are the clinicians who are active in the field. We also invite the companies to provide feedback on guidelines, but the companies are not actively participating on a meetings or writing process. We could hear yesterday great talks of Professor Data and Professor Bodis on the meta-analysis of the clinical trials and need for clinical trials. What is very important that all the positive trials actually show a strong evidence that the treatment quality is positively correlated with treatment outcome, and that it is the temperature achieved in the target area that matters. So the fundamental principle that the Azure Technical Committee is working along is that temperature or hyperthermia means a temperature increase. We know also this, the studies that fail to demonstrate the benefit of adding hyperthermia, they actually had a poor quality of the heating and heating equipment. As an example, I have two studies in the breast cancer. The first one, this one, show actually that if you achieve a thermal dose higher than 6 minutes, you obtain a significantly higher local disease-free survival, while if the heating quality is poor, as in this case, there is no difference between RT or RT plus hypothermia, or actually the result is even worse. As another factor, you can use SAR coverage, and this has been shown by Lee in a study of Vernon, that if for those patients where the SAR coverage was higher than 25%, the outcome was significantly better. In this case, the complete response was significantly better than in the other group. As you all know, there are many uncertainties in hypothermia treatment, and optimally we would like to have our devices like a black box when the clinician just push the button and the treatment is performed. And in our case, we obtained a temperature increase in the tumor area. Unfortunately, we have a number of unknowns or uncertainties, and very often these comprise from the heating devices itself. So what kind of heating system we are using, what is the applied power, what kind of frequency we should use, what should be the water bolus temperature, etc. Very important factor is also patient positioning, because if the applicator is placed in a different way as our treatment planning, of course the temperature increase in the tumor is lower, and then we also have a high risk of hotspots. And we have our largest uncertainty is actually the patient itself, and especially the perfusion of the patient. Finally, we need to measure temperature, and also there are many, we must ensure that the thermometry is correctly performed as well. So the aim of the QA guidelines is to reduce number of these unknown or uncertainties, and to provide the user with tools to convincingly demonstrate that the heating equipment can deliver the dose he planned for. We, so far, in past few years, we consider the classical hyperthermia, and we focused on superficial guidelines, deep guidelines, and interstitial guidelines and techniques. There are different devices that can be used, and we aim to include all the devices into the guidelines. In general, we have a recommendation, and there are always two parts of the guidelines, the clinical and the technical aspects. In clinical aspects, we focus on treatment delivery, and in the technical one, it's a characterization of heating devices. But first of all, before we started, we actually asked the clinicians what is a good quality hyperthermia treatment. And the consensus reached at the end was that, at least for superficial hyperthermia, the goal should be to achieve 19th percentile temperature, T90, of 40 degrees C for 60 minutes. While the median temperature in the tumor should exceed 41 degrees C, and the maximum normal temperature should be in the range of 43-45 degrees C. And you can discuss this. We mainly the superficial techniques are mainly delivered together with radiation therapy. So you can argue the temperatures, but this is the consensus. For deep hypothermia, we know that with the present devices, the goal above is challenging to achieve, so we can accept lower temperatures. For interstitial hypothermia, the goal is the same, but we must be aware that there are steep thermal gradients, and the location of thermal sensors really define what is the temperature measurements, because today, very typically, we measure T minimum, T10 in interstitial techniques, and there will be a talk later that will actually point this point more in details. So if you look at the clinical aspect, we prescribe what should be the treatment delivery, and the treatment duration should be 60 minutes. Treatment start at low temperature or low power, followed by stepwise increase of power during the first 10 minutes. And the focus of guidelines was actually to prevent the potential problems that can appear during the treatment, to highlight all the possible challenges one could have. We also suggest the staff requirements, the role of different professions and their training, and then also define the role of treatment planning. And this is important because for superficial interstitial hypothermia, we require only generic treatment planning, not patient-specific. Patient-specific is typically applied at academic centers for challenging tumor locations, such or if you have implants, etc. For deep hypothermia, patient-specific treatment planning is mandatory. And finally, we also mentioned the importance of documentation and what are the minimal requirements. When we go to technical aspects, we need to characterize our heating devices. And that's by characteristics of the heating properties. And we have a fundamental requirement. We welcome all the systems, but all the systems must show that they are capable of delivering heat into the body. So a heating device is considered as adequate if a temperature rise of 6 degrees C is achieved in 6 minutes. And now we are talking in the muscle phantom. And then this is the fundamental. This is the first step. And in the second step, based on the type of device, you have to show different abilities. So for deep hyperthermia, you need to show that the applicator is able to focus and to steer the energy, left, right, or top, bottom. In superficial systems, we need to define what is the effective field size of the applicator and what is the penetration depth, in which is the lowest or highest depth we can apply. This is and in interstitial techniques, it is effective heating length of the applicator, and we have to show also independent steering, that independent steering is possible. So as an example for a superficial heating device, the setup is following. We have a phantom, bolus, and the applicator. And then we look in 1 centimeter in the muscle phantom and measure the temperature effective field size, which is 50% of the maximum. It's a contour with 50% of the maximum achieved in this slide. So this is this white dotted line. And optimally, this effective field size is larger than your applicator aperture, because then you can combine several applicators and you know that you can cover very well the treated area. The penetration depth, again, we take the maximum temperature 1 centimeter below the surface of the phantom, and then we take a 50% maximum in the depth. So here you can see now we are going in a vertical, and that will give us the temperature effective penetration depth. So in this case, the applicator can be used to treat tumors up to 4 centimeters depth. In interstitial hyperthermia, as I said, we have to evaluate that every single applicator is a good radiator, and we do it in a simple setup with a cylindrical phantom. But then also we need to prove that the array of applicators, that every single applicator in this array can be independently steered. For deep devices, I would say the guidelines are, from technical point of view, are not updated yet. We still rely on SAR, and there is a requirement that SAR in the target location should be 50% higher than in the target area. Then it is necessary to do a periodical and reproducible measurements that controls that or checks that the phase steering is possible, and also what is the field size determination. But these guidelines are going to be updated in the near future. This is our present work, and you will hear later in this session what are our thoughts about it. So this is the overview of the actual guidelines. We have the technical and clinical aspects in 2 publications on superficial hyperthermia, in interstitial hypothermia that was just published recently, and the deep guidelines are now being updated. So thank you for your attention, and if you have any questions, I'm happy to answer.
Are there any questions?
Mm-hmm.
There was a curve which I do not understand. For the superficial hyperthermia, you showed the curve, which is, can you show it again?
I can't, but I can ask.
I think this was a temperature curve, which shows in the beginning a low temperature and then increasing. Yeah,
You mean here?
This one. And what is it? Does it mean? Is it a temperature curve? Or?
That's the temperature. Yeah, the blue is the temperature curve, and the orange is the SAR. And the aim of having both, and you can say that the originally the effective penetration depth was considered. Yeah. That was in all guidelines, and what we wanted to show that actually the coming or going from the SAR to temperature will not make a big difference.
Is it a static phantom?
Yeah. This is a phantom, and then we had.
So finally, the temperature will be higher if you wait, if you heat longer. So this is
of course,
at present a special time. Or?
No. Yeah. Yes, we have a time. We have 6 minutes.
6 minutes.
Yeah.
Okay, so it's at a certain time, the temperature. Okay, thank you.
We have time for a short question.
Good morning. I would like to ask why exactly 60 minutes and not less?
Well, it depends, and I think that most of the treatments are performed for 60 minutes just to achieve your thermal dose. If you look at the cumulative equivalent minutes, this is to ensure this. Of course, if we would be able to heat at higher temperatures, then one could go for lower. But this is to assure that the thermal dose is achieved.
Thank you very much, Hannah. I think we should move to the next speakers.